So Beth, while I have you there, we did have one question from one of our online viewers about does the PED readiness, or do you have any data about how the readiness score really relates to trauma morbidity, pediatric trauma morbidity and mortality?
The closest we've gotten to that process of getting close to outcomes, Dr. Mark Auerbach out of Connecticut has a process where he goes and does simulation in the emergency departments, and he's recently published a paper that showed increased competency of the care providers in following protocols or cares in 5 scenarios was associated with an increased pediatric readiness score. That is our next goal, is to link that pediatric readiness with outcome data. So that's the direction we are headed. We're not there yet, but again, I think it'll be very illustrative to provide some credibility to the process.
Great. And Ben, I just wanted to come back to you about your thoughts on technology to help with the global problem. We've heard about it throughout the afternoon already.
There is certainly a role for, tele-mentoring. But I think when it comes to direct clinical care in an emergency setting, it's pretty challenging at this point. Apart from obvious issues with liability, concerns, many of those centers don't have electricity. I mean, you can't even count on, having electricity at a point of care. So, I think in terms of all the tele health initiatives that I have heard have all part of an integrated trauma system. So I think it is a little bit challenging trying to devise telehealth situations in international settings, particularly in areas that have suboptimal technology and suboptimal infrastructure. But I think that there is certainly a role with education. I know that Todd and I have talked about even how what GlobalCast is doing can be used to enhance the education of pediatric surgeons in sub-Saharan Africa, and I think there is certainly a role for that. Obviously, some minimal funding will be required to actually get it off the ground. I also know some very enterprising work done by people like Erland Okrenik at Toronto, who uses just Skype to do telementoring of surgeons down in Southern Africa. So I think there is certainly some possibilities in that direction.
There's a question from the audience about how does the liability in telehealth across health systems work out. And before we open that up, a quick comment that the whole concept of telementoring is obviously very exciting, very new. Everyone's very intrigued by it because our technology has finally caught up to the point where we can do it realistically. That the American College of Surgeons and SAGES and APSA all have committees on this. And I would encourage all of you, if you're interested in this, to help join, to help define the rules, because they're not defined yet. What is the liability? The liability is debated, but most of these societies are coming out with the recommendation that an expert who is mentoring is liable if something goes wrong. So we don't have definitive rules yet, and there's no real examples of it happening. But that's generally that if you're going to be mentoring, you have to realize that you are at risk.
Great. I want to just ask the panel if you have any other questions.
I've got a question for Todd. You're in a unique position as a pediatric surgeon, care provider, but also sort of organizing a state's trauma system. I'd be curious to know if you could comment a little bit about some of the recent experience with Florida, about proliferation of trauma centers and sort of the free market forces, and sort of what's the right balance. There is probably something to volume and outcome, but you already mentioned that your state has 4 corners and you're in the center and your reach is only so far. How do you, at an organizational or state level, how do you put all that together to make recommendations and verify centers and that sort of thing?
This is a great point. Ronnie Stewart and his leadership at the COT convened a group in Chicago about a month ago, and there were folks from HRSA, the state of Florida, and the HCA system, and everybody got together and just put it on the table. Volume matters. Volume matters in outcome. It matters in competency. And there is some intangible to protecting the training of the future group of surgeons and emergency medicine docs in this country. And so it's important that we discussed it. The college is working on at least a tool that lead agencies or states can use to examine the right number of trauma centers in their state. And it's based loosely off of the Florida model that state developed. It's got proponents, it's got detractors, but it seems to be the best tool that's being used. And I think within the first part of the calendar year 16, you'll see the college come out with that tool that systems can use to evaluate not only what centers, where centers are needed in the state or in the region, but maybe when a region or area has too many trauma centers in it. So, and it takes all those things in consideration: training and volume, and time distance from centers. So, the college at least is addressing this through Dr. Stewart's leadership.
Thanks. Thanks to all the speakers for staff. I'm going to just take the privilege of leading this just to kind of comment on my own biases, and I'm glad to have heard it here. I mean, I think collaboration and figuring out how those of us that are committed can reach out and help both globally, locally, regionally, other centers and other pediatric places that are going to see kids, whether they want to or not, get better. Todd alluded to our program here, Pediatric Trauma Transformation Collaborative, and that's been a group to really help some centers that wanted to build up to be level 2 centers without all the traditional resources that we think of pediatric subspecialists, and have been able to improve their care. I think models like what we're trying to do and models like what Steve's doing and Todd's doing, I think are what's going to help us improve the pediatric readiness, improve the pediatric trauma care nationally, regionally, globally. So I thank all of you for your talks this morning. I hope you stay on for the rest of the afternoon. We're going to take a brief 10-minute break and then come back with our afternoon session.
Before we
Please.
go to break, we posted a link in the chat box. If you want to get CME credit for this, follow that link, and it will take you to another chat room where you can have side chats and more robust commenting. Polls are there as well. You can visit the exhibit hall where you can see more about Cincinnati Children's and about the Childress Institute for Pediatric Trauma. But you can also get all the lectures that were given, the PDFs of all the talks that were given, and also the link to be able to take the CME test to get your credit. So please follow that link, and we will see you back here in about 10 minutes. Thank you.